First myth, exercise during pregnancy can hurt my baby's health. So if we look at in pregnancy, physical inactivity and excessive weight gain, these have been recognized as independent risk factors for maternal obesity and related pregnancy complications, specifically including gestational diabetes. The main concern has been that regular physical activity during pregnancy may cause a number of issues, including miscarriage, poor fetal growth, various musculoskeletal injuries, or premature delivery. However, all these things have not been substantiated in the literature, especially when you're looking at women with uncomplicated pregnancies. So if we now look at the association of pregnancy and exercise in terms of guidelines, really the first guidelines came out in 1985 by the American College of Obstetrics and Gynecologists, ACOG. And so here they listed that they wanted to limit exercise to no more than 15-minute intervals. They also recommended in their guidelines to keep heart rate, the maternal heart rate, less than 140 beats per minute. They also recommended that for previously sedentary women, that they should not begin an exercise program during pregnancy. Specifically, the thought process behind that was that obesity and sedentary maternal lifestyles were really considered relative contraindications to exercise in pregnancy. And lastly here, that they recommended that previously active women should really reduce exercise intensity to prevent fetal harm. Then if we fast forward, you have in 2002, ACOG now came up with updated guidelines in regards to pregnancy, exercise recommendations in pregnancy. And you have subsequent groups who have also supported the guidelines that were produced in 2002 from the US Department of Health and Human Services in 2008. And you also have the 2011 American College of Sports Medicine position statement. Basically, all these groups recommend that for healthy women with uncomplicated pregnancies, the recommendation is very similar to the exact same as the recommendation for physical activity in the average American, which is 150 minutes of moderate intensity, which they're considering 3 to 6 metabolic equivalent of aerobic activity a week. So this can be divided up into 30 minutes a day, at least 5 days a week. And so this has been found to be safe during pregnancy and in the postpartum period. Specifically, if we look here at the on the right here, this is the chart that lists the metabolic equivalent tasks. And so you have in the middle here that I have highlighted in yellow, those that are considered moderate activities. And so this ranges from sexual activity to stationary biking, also to walking. So this study here, now we're going to move into the recommendation for moderate to vigorous resistance exercise during pregnancy. So this study was published in 2015. Specifically, it was looking at this moderate to vigorous resistance exercise during pregnancy, specifically using the various outcome measures, health-related quality of life, physical strength, pain, weight, blood pressure, functional status, activity level, and specifically perinatal data. So what this study found was that with resistance exercise during pregnancy, there really was no difference in health-related quality of life measurements, physical strength measurements, and specifically perinatal data. And so the conclusion from the study was that supervised moderate to vigorous resistance exercise does not jeopardize the health status of healthy pregnant women or their fetus during pregnancy. And instead, resistance exercise does appear to be an appropriate form of exercise in a healthy, uncomplicated pregnancy. Now, ACOG also has released some specific guidelines in regards to contraindications to aerobic exercise, and you can extrapolate this also to resistance exercises during pregnancy. So if we look at the far left column here, this is listing absolute contraindications to exercise, aerobic exercise during pregnancy. And so this includes pregnant patients who are suffering from preeclampsia, who have a history of ruptured membranes, those who have restricted lung disease. The middle column here is specifically looking at relative contraindications. So this includes severe anemia, things like poorly controlled hypertension, poorly controlled type 1 diabetes, one who's a heavy smoker. And in the far right, that column is specifically looking at warning signs for exercise termination when one has initiated exercise. And we'll kind of go over this last far right column on another subsequent slide. So now if we look at the ACOG recommendations for exercise by sport, so the majority of the recommendations center on for pregnant women to avoid exercise or sporting activity that increases risk of falls or increases risk of collisions. So the things that are recommended are things like walking, swimming, stationary cycling, low impact aerobics, and as I said, also with resistance exercises, so looking at using resistance bands and even weight training. So in regards to sports to avoid, the recommendation, as I said, it relates to decreasing risk of falls. So this means not engaging in sports like gymnastics, horseback riding, downhill skiing, also decreasing risk, decreasing collision risk. So decreasing or not engaging in sports like basketball, soccer, ice hockey, rugby while one is pregnant. And on the far right, these are extremely risky sporting activities, including scuba diving, lots of literature in regards to decompression, illness, trying to avoid high altitude hiking, and also really avoiding surfing, water skiing. All these are very high risk activities for a pregnant female. So in summary, for this first myth here regarding strenuous exercise during pregnancy can hurt my baby's health, the summary here is that in absence of obstetric or medical complications or contraindications, physical activity in pregnancy, it's safe, it's desirable, and pregnant women really should be encouraged to engage in these safe physical activities. So now moving on to the second myth under the pregnancy and exercise category. If you do not usually exercise, you should not start during pregnancy. So this is false. Basically in 2008, again, looking at the US Department of Health and Human Services physical activity guidelines for Americans, it has a subset on regarding pregnant women. Essentially, it's in the absence of contraindications, a woman really can begin or maintain a moderate intensity physical activity regimen during pregnancy and also in the postpartum period. The main recommendations here are that for those women who are quite sedentary or minimally engage in exercise prior to becoming pregnant, that they slowly ramp up to that 150 minutes per week recommendation for pregnant women and for the average American. And so again, here to the far right are just the charts with the metabolic equivalents for moderate intensity activities and for activities, again, sporting activities that are safe during exercise. So the next myth, athletes who continue vigorous exercise throughout pregnancy, athletes can continue vigorous exercise throughout pregnancy without cause for concern. So essentially the recommendation here is that for highly active pregnant women, specifically with uncomplicated pregnancies, that they can continue at their physical activity level that is quite intense, at least initially, with the goal of really adjusting the intensity over the course of one's pregnancy. So really working in close connection with one's OBGYN and any health provider, whether that's their sports medicine physician or who else is helping provide their care during their pregnancy period. The important thing to note for patients who are highly active and for just in general for any pregnant patient is that any exercise activity should be terminated if there are certain warning signs. And so ACOG again has listed those warning signs that I have pictured here on the far right. So this includes vaginal bleeding, worsening headache, muscle weakness, any kind of preterm labor symptoms. Exercise should be aborted. And last in this category, the only value of exercise during pregnancy is to help you lose weight more easily after your baby is born. And so the reason why that's false is that there are a number of benefits associated with exercise in pregnancy. One is a higher incidence of vaginal delivery when you compare that to pregnant women who don't exercise, and there's a little bit of an increased rate of cesarean sections. In terms of, again, other benefits, there's a lower incidence of excessive gestational weight gain, lower incidence of gestational diabetes, lower incidence of gestational hypertension, and specifically looking at gestational hypertension and development of preeclampsia during pregnancy. There's also a lower incidence of lower birth weight for the fetus. So if we now look at practice and research gaps in the area of exercise recommendations during pregnancy, pregnant women really are not receiving a counseling to be physically active during pregnancy when you look at the literature in terms of the actual numbers. So this study here that was published in 2014 was looking at US provider reported diet and physical activity counseling among OBGYNs in this column right here, and also among non-OBGYN physicians, which is this oblique striped column on here. And so basically you can see here that the recommendations for pregnant women, or in terms of the recommendations for exercise, is pretty low. It's at 18% for both OBGYN and non-OBGYN physicians, as opposed to when you look at the far right non-pregnant population, with the non-OBGYN physicians having a significantly increased level of recommending exercise for that patient population. And that stems about, it's a little over 25%. So if you jump down to number 4, one of the other practice and research gap areas looking at exercise recommendations during pregnancy is that we don't really know what the upper limit of exercise is. And so there is no upper limit that if one reaches that limit, that puts their fetus at a significantly increased risk. And so this is an area that more research definitely is needed. So in terms of take-home points, essentially women having healthy, uncomplicated pregnancies should be encouraged to be physically active throughout their pregnancy, with the goal of achieving the recommendation of the 150 minutes per week of moderate intensity activity. Fit pregnant women who were habitually performing high intensity exercise before pregnancy can continue doing so during pregnancy. The intensity level just needs to be adjusted accordingly throughout the progression of their pregnancy. And this also assumes that the pregnancy is uncomplicated. And lastly, I think it's just important for all of us to note that pregnancy it's a condition. It's not considered a disease. And really the pregnancy period and the prenatal care that's associated with a female being pregnant is really an ideal time for lifestyle modifications. You know, the majority of pregnant women do have access to medical care and are quite under close medical supervision. So pregnancy really is an ideal time to engage in lifestyle modifications, which, you know, an important one would be continuing exercise or adding exercise to one's life. Now moving to our next large mythbuster category. So this centers on females, periods, sports and exercise, and general bone health. So the first myth: if I'm not getting my period, that means that I'm training at the right level. So first, I think this is defined as amenorrhea, secondary amenorrhea. So I wanted to just define what amenorrhea is in the first place. So primary amenorrhea essentially is an absence of menses by age 15, or the absence of breast development by age 13. Secondary amenorrhea, which is what this half of the talk is going to be talking about, is looking at specifically for a female that has established regular menses that have either stopped for longer than 3 months, or a female that has irregular menses that have stopped for greater than 6 months. So if we look here at this diagram here, so this divides up, again, amenorrhea into some specific categories, looking at the physiological amenorrhea and pathological amenorrhea, which secondary amenorrhea falls under. Physiological, you have your puberty, so when one has not started their menses, you have pregnancy related, and obviously menopause. So we're going to be focusing again on that secondary amenorrhea, which is considered pathological. So amenorrhea and exercise. Getting back to the main question here, it is never normal for a female athlete to stop menstruating. Specifically, losing periods during the season, it's not a normal response to training. Amenorrhea really should be a red flag to the athlete, to the coach, to the parent of the athlete, that the body really is not functioning at its full potential. And so all women with amenorrhea really should have a thorough evaluation. That includes labs. You want to evaluate for or rule out pregnancy. You want a full endocrine workup. And you do want to look at low energy availability versus exercise. So energy in versus energy out. Now, for the athlete that does have amenorrhea, the most common cause of that is what we call functional hypothalamic amenorrhea, so FHA. Essentially, the hypothalamus that's pictured here it's a regular center in the brain. It releases hormones which control multiple bodily functions, including the reproductive system, which is what we're discussing here. So with FHA, the hypothalamus is essentially silenced, and so this ultimately impairs a normal menstrual cycle. And so FHA has been found in the literature to be caused by low energy intake, exercise, weight loss, stress, and a combination of these factors. So the next myth buster under the second category: if I'm not trying to get pregnant, not having periods is okay. And essentially, amenorrhea, it's something to worry about. It's like, as I mentioned in the previous slides, it's not normal. And when we look at estrogen, it's key hormone for many essentially bodily functions in a female. Some long-term consequences of amenorrhea include increased risk of developing endometrial cancer, germ cell tumors, osteoporosis. Females also have an increased risk of fracture, increased risk of bone stress injuries, increased risk of developing various cardiovascular disease, and increased risk of infertility. So amenorrhea is very important. It's something that shouldn't just be not thought about and not treated effectively. All right, so if you have amenorrhea, you should start oral contraceptive pills, OCPs, to induce a period and keep your reproductive and skeletal system healthy. So OCPs, they can play a role in the treatment of select menstrual-related conditions and pregnancy prevention, but amenorrhea that's due to functional hypothalamic amenorrhea really isn't one of them. And so amenorrhea, again, it can be a sign that one's natural hormones are not working properly and should always be fully evaluated before considering starting OCPs. When you look at just the mechanism of OCPs, essentially they can mask when one resumes natural menstrual cycles, as the hormones in the oral contraceptive pills, they induce bleeding, thus they can mask the natural menstrual cycle, especially when it resumes. And so it's really just not an adequate or a treatment that should just be used for functional hypothalamic amenorrhea. And definitely any athlete that is that presents with amenorrhea should have a full workup. You want to make sure you rule out any of the causes of amenorrhea. So that's very important. And that's what I have for today. So thank you. And I have my email address listed here if anybody has any additional questions.
Thank you, Dr. Bunadike. If anybody has any questions, if they would put them in the Q&A at the bottom of the screen, there will be a panel discussion at the end of this presentation or this section. Up next, Anna Cottle will be talking about ACL tears and injury prevention.
All right, let me pull up my PowerPoint. Hi, everybody. I'm Anna Cottle. I'm a physical therapist at Emory. I work at the Dunwoody Clinic, and I'm also an athletic trainer. And today I'm going to be speaking on preventing ACL tears and knee injuries in female athletes. So first, kind of going to go over the incidence of ACL tears in female athletes, identify some risks for ACL injury in females, provide some general strategies to prevent those injuries, and go into sport-specific training just a little bit. So starting off with the incidence, I'm sorry, I'm not even, there we go, that's better, okay. So the highest incidence of female ACL tear at higher playing levels occurs at higher playing levels. So this is logical. The more you play, the more opportunities there are for injuring your knee. So a study in a Scandinavian Sports Med journal found that 0.82 ACL injuries occurred per 1,000 playing hours in women compared to 0.31 ACL injuries per 1,000 hours in men. So you do see a considerable difference in the incidence between males and females when talking about ACL injury. So we'll take a look at the graph here. You see a huge spike in ACL tears in females from the ages of 15 to 19. This is a good visual that you can kind of see that this happens a lot more in those younger age groups in females. This is the age where we as coaches, parents, healthcare providers have to be especially attentive to the risks of ACL injury for our female athletes. All right, so what are those risks? There are two categories of risks: non-modifiable risk factors and modifiable risk factors. So things we change and things we can't. We'll start off with the non-modifiable risk factors. So female gender, so females are definitely at a higher risk for ACL tear because of some structural things. The Q angle is an angle formed by connecting the line of force from the quadriceps to the vertical. And because females have a wider pelvis, this angle tends to be wider in females, and this represents increased lateral force on the knee. The intercondylar notch width also tends to be less in females. And menarche plays a part, which is the age of onset of the period, which can play a factor in growth and maturity of that female athlete. And then age, so less than 14, as you saw on the graph in the last slide, you're at a higher risk. Those lower ages are at a higher risk for tearing ACL just because of maturity, growth, strength, things like that. Previous ACL or knee injury. So if you've torn your ACL before, you've injured your knee before, you are at a higher risk for injuring it again. And then sport and playing surface. So technically, you can alter these two risk factors, but I throw them in the non-modifiable category because many athletes don't have a choice of playing field or what sport they play. All right, modifiable risk factors. So strength, coordination, balance, core stability, landing mechanics, fatigue, cumulative hours of training, BMI, and footwear are among a bunch of other modifiable risk factors. Landing mechanics, we'll go into in depth with this in a little bit, but specifically increased knee abduction or knee valgus in landing. Fatigue, so hydration and nutrition play a huge role in this. I know there are a couple other speakers talking about nutrition today, so that would be great to tune into as well. But hydration and nutrition play a big part in energy level and fatigue, as well as cumulative playing hours. So how many days or hours are spent in practice or in games per week? And what is the intensity level of those practices? Are you kind of tapering off your practice intensity before a game? Are you making sure to pay attention to your athlete's fatigue level as you're training to kind of adjust those hours to make sure that they don't get injured? Okay, we'll go into some strength. So weight training is a really important factor in preventing knee injury. But it also plays a big part in preventing any injury, not just ACL tears. The main muscle groups we want to look at for ACL tears are hips, quads, hamstrings, and core strength. So the hip muscular can include the glutes, glute max, glute med, and then the hip flexor group as well. All right. So creating a stable base of support for the body by building strength in these muscle groups is important in any sport that any female athlete's going to play. And it's our job as parents, coaches, athletic trainers, physical therapists, physicians to make sure that our athletes are doing this safely. So we need to be on the lookout for form with exercise. We need to be on the lookout for fatigue. And these can be precursors and warning signs for injury. So take a look at this picture here. You can kind of see the difference between a correct and an incorrect squat form. So this is the single leg squat. It's a great staple exercise that is good for detecting risk factors for injury. And it's also a great way to strength train and promote stable single leg movement. So another good exercise to implement into any practice with any sport. So when you're looking at the form, you want to make sure that the hips remain level. So under the athlete where it says right, her hips are level. Compared to the athlete on the right side of the screen, her hips are kind of at an angle, which you don't want. You want to make sure those hips are even. The hip, the knee, and the toes are in line, especially with a single leg squat. You want to make sure that knee's not going in. You want to make sure that the athlete is sitting back. So I tell all my athletes and my patients in the clinic, whenever we're squatting, make sure you get your butt back. You're keeping your knees over your toes and make sure they're not going forward. So this is what you should look for when you're trying to correct your athlete's squat mechanics. Okay, coordination and balance. So another Scandinavian study by Wetterkop found that the use of an ankle disc for balance training at each practice session decreased the injury risk for female athletes. And this is overall injury, ACL, ankle injury, hip injuries. Adding some form of balance into your training session is a fantastic way to prevent those injuries. Now, not every team's going to have access to an ankle disc, but this does show the importance of taking a few minutes out of each practice to work on that balance training. So we use a Bosu ball and Eric's pad in the clinic, have them do some dynamic movements on a single leg to train balance. And then coordination. A great way to train coordination is through agility drills. Athletes should be working on sport-specific movements in practice, especially direction changes and footwork for those sports that require unexpected or unplanned movements. A great example of that is soccer and basketball. You're having to avoid other players, make certain movements at certain times. And agility training is a great way to help prevent injury that way. Okay. Core stability. So the core can be defined as the abdominal muscles, the back extensor muscle group, and hip musculature. The center of gravity is located within the core, so this is important for controlling balance with dynamic movements such as running, cutting, and jumping. With a strong core, athletes can control movement better and have better reaction to abnormal forces like an unexpected pivot by a basketball player avoiding her opponent. There are so many core exercises you can incorporate into training, but I've taken two that I love here and shown them. So a plank on the left, so you can do a normal front plank. I have a side plank shown here. You can adjust this in so many different ways. You can add a twist to it to make it dynamic. You can add a leg lift. You can have them hold on their extended arm completely, on their elbow, and the bridge as well. You can adjust, you can throw an Eric's pad underneath their feet or underneath their shoulders to work on balance a little bit. You can have them do a single leg bridge. So these are two great exercises along with so many others that I didn't put on here that can train core stability. So we need to be making sure that all of our athletes' training is well-rounded, including strengthening of the extremities in the core and other sport-specific aspects of play. So next up, we'll take a look at landing mechanics. There are plenty of things to look out for in your athletes when they're jumping and when they're landing. So the most obvious concern in this picture, which I've already kind of talked about, is the knee valgus angle in landing. So you can kind of see that in the second and fourth pictures where her knee goes in as she's coming into a landing position. We need to look out for buckling at the knee because this indicates a lack of lower extremity strength, a lack of core strength. If you notice this form in any of your athletes, it needs to be corrected, okay? You can also notice on the right that the athlete moves her body and her torso over to her right as she's jumping. This means you kind of have some core and hip strength that need to be addressed there as well. Again, most of the time you can correct these mechanics through cueing. So just tell your athlete, hey, this is what I see, try this next time, and have them train that for a minute. If you have access to a mirror, have them do some of these jumps in front of a mirror so they can see what they're doing and use that visual feedback to correct. If you're on the field, take a video, take a picture of the athlete as they're jumping and landing and say, hey, we need to fix this, this knee angle or what you're doing right here to kind of correct that form, because form is a very important aspect of preventing ACL injury. All right, so the last thing I want to cover is sport-specific training. The most research we have for ACL injury is with soccer, and that's why the FIFA 11 Plus program was developed. This is something that we recommend be implemented a few times a week at a couple practice sessions as a warm-up drill. These drills can be used for other sports as well, so not just soccer. But research has shown that the FIFA 11 Plus plays a very important role in preventing ACL injury, but also any sort of lower extremity injury. And there's even a kids version. You can go online and Google it. It'll come up, but also I have my email address at the end. So if you need a resource, just send me an email. So the FIFA 11 Plus includes a variety of running, strengthening, balance, and plyometric drills. It's been shown to reduce injury risk for ACL tear and overall injury risk for other injuries. It was first tested in Norway, and it was pretty much proven that this helps prevent injuries. This is a great resource for anybody looking to have a variety of things that can be a comprehensive resource for preventing these injuries. So use it as a structured warm-up program, have the athletes do it twice a week. And the greater the compliance with the FIFA 11 Plus, or the more times you perform it, the more regular you are with it, the lower the risk for knee injury. So those teams that are performing it twice a week, every week, those are the teams that are going to have the least amount of knee injuries. And here is a graphic of the exercises that are included in the FIFA 11 Plus. The first part is running exercises, takes about 8 minutes. You can kind of pick and choose too if you want it. If you don't have 20 minutes to do this, pick some of the exercises. Part 2 is strength, plyometrics, and balance. So you can do an advanced, intermediate, or beginner version. There are different core, lower extremity, hamstring, quad strengthening exercises that are great for lower extremity athletes. And then the last part is another group of running exercises. So like I said, this is mainly geared towards soccer, but any sport should be involving sport-specific balance, coordination, agility training in their practices just to help prevent these knee injuries. All right, and that is it. Thank you so much. I hope this talk was helpful for you guys and can give you an idea of what to look for to help prevent ACL injuries. Please feel free to email me or put any questions in the Q&A section. And thank you so much.
All right, thank you, Anna. We will keep moving right along here. Our next presenter is Dr. Anna Cruz. She will be presenting on acupuncture.
All right, hey everybody. Just gonna share my screen here. Sorry guys, gotta get to the beginning. Okay, very good. So my name is Anna Cruz. I am a non-operative physician at Emory as well. I have a clinical interest in acupuncture, so we're going to talk about some of the basics of that today. So in terms of the outline, we're going to talk about the basics of traditional Chinese medicine, which is the big umbrella under which acupuncture lives. Then we're going to talk a little bit about meridian channel theory, the physiology of acupuncture, how it works, and then a little bit about the nuts and bolts of treatment, some of the details. So the first thing I want to talk about is traditional Chinese medicine. It is a patient-centered approach to disease, and we're looking at the patient in a holistic way. So it's a little bit different than what we normally think in Western medicine. I thought this table was helpful because it kind of tells us, it kind of compares the two. So the first part is disease and illness. In Western medicine, when we think about disease, we're looking at a specific organ or body part, like your knee or your heart or your lungs or your brain, versus in traditional Chinese medicine, it's more of an energetic disharmony in the whole body. And in Western medicine, we're looking at an organ, like I was saying, and it's about the physical structure, something's wrong with the organ, versus in traditional Chinese medicine, there are organs, but they're more a function. So we're looking at the complex interrelated groups of function between the organs, which is not really a physical thing we're looking at. So in terms of pathophysiology, pathophysiology is a study of the disordered process in the body, and that's what causes disease. And when we think about it in Western medicine, we think about something causes a problem in the body. So an injury like a fall can cause an ACL tear. Versus in traditional Chinese medicine, we're looking at, we're recognizing the patterns of imbalance and disharmony, and it's more of a circular way of thinking about it. And then goals of treatment. I think this is probably the most different. In Western medicine, we treat the disease with an external agent. And that means we're using medicines, physical therapy, injections, braces, surgery. So we are doing something to the person. Versus in TCM, we're trying to reestablish harmony in the body by stimulating the body's own natural healing abilities. And we'll kind of talk about how that we can actually do that. So the basis that we could do that by is talking about qi. So qi is this dynamic vital energy within our bodies, and it regulates the function in our bodies. It is composed of two opposing forces, yin and yang, as you can see kind of in the top right corner here. The major functions of qi, it's involved in movement, protecting the body from disease in the outside world, transforming the food into blood and urine, and keeping your body's substance, keeping the organs in place, warming the body. So why is qi important? Illness occurs when there's an imbalance of yin and yang, and therefore qi. And so when we say there's disease in TCM, there's an excess or blockage of qi or a deficiency of qi. And so the goal is the arrival of qi. And the way that you can do that is by nourishing a qi deficiency, releasing excess qi or opening a blockage of qi. And acupuncture is one of the ways to manipulate qi, but there's a whole lot of other ways where you can manipulate qi, and that's that umbrella of TCM that I was talking about. So these are all the treatments in TCM. Acupuncture is one, but the other kind of categories include nutrition, energy treatment like Qigong, mind-body interaction, which includes meditation and breath work, mind-body movement, which is Tai Chi, herbal medicine, ecological medicine, behavioral medicine, sleep medicine, manual therapy, spiritual counseling, lifestyle medicine. So when you look at the breadth of these treatments, it really addresses all parts of your life and all parts of your body as well. We're going to focus mostly on acupuncture today, though. So we're going to talk about meridian channel theory. So this is kind of the basis of what acupoints are. Qi travels through these meridians in the body. And as you can see on the right here, it's kind of a map of the different meridians. It's not the same as a blood vessel. It's not the same as a nerve. And we'll talk about kind of what makes up an acupoint and the network that it actually is. So there's 12 principal meridians in the body. There's 8 extraordinary meridians, and the meridians connect the outside to the inside of the body, and that's kind of how we base our treatments in acupuncture. There's 4,000 known acupoints. 361 acupoints are on the meridians, and 170 are the ones that are commonly used. The meridians, as you can see here, they're all related to an organ, but it's not related to a physical organ, like I was saying before. And some meridians are more important for different conditions. So musculoskeletal conditions are usually associated with the liver, spleen, and kidney meridians. So that's what I usually use. And when you're choosing an acupoint on that meridian that's related to your problem, but also acupoints on a different meridian nearby the area of the problem, and then other pain kind of points nearby. And in a session, you usually use 4 to 20 acupoints at one time. And the basis of acupuncture is you're stimulating the acupoint on the outside of the body to get that therapeutic effect inside the body. So what is an acupoint? You know, we think about what is at that point that makes it so important and why it's so specific. So we think about the neural acupuncture unit, and you can see this picture here. Acupoints are shown to have relatively high concentrations of free nerve endings and bundles. That's all these things on the right here. On the left. And then on the other side, you have different kinds of blood vessels and capillaries, mast cells. So each acupoint has a lot of different things going into it. And it's not necessarily a nerve, like when we think about a structure. It's kind of an environment that has input from the nerves and the blood supply as well. And when you stimulate an acupoint, like you are here with a needle, you are sending a signal that stops the pain signal from getting to your spinal cord and your brain, so you don't feel the pain as much. That is one way the stimulating acupoint works. And then also, when you stimulate an acupoint, it starts the production of opioids, endorphins within the body. So it kind of causes the internal pain relievers to be released to kind of help with pain and treatment. So that's part of helping your body reestablish harmony within the body. There is a lower electrical resistance at this acupoint, which means that the skin at this acupoint compared to a non-acupoint site can conduct electricity better. So between acupoints, it's more of like an electrical connection, sort of. So acupoints versus trigger points. I think I get this question the most. Trigger points are well known and are getting treatment better now than they ever have been before. And I don't think that acupoints and trigger points are necessarily separate. I think they are related. A study in 1977 showed that there's 71% correlation between well-known trigger points with an acupoint. They were near each other within 3 centimeters. And then the clinical pain syndrome pattern was similar in both. And they confirmed this in 2006 by another study where it showed that they were with the trigger points were within 2 centimeters of a known acupuncture and within the same muscle as well. And then the myofascial pain patterns were in complete agreement in the meridian distribution. So I think that acupoints and trigger points are actually pretty related, but they're not exactly the same thing. But I think that it's something that we can relate to now in Western medicine compared to acupuncture medicine. They're the worlds are kind of melding together when we think of this. So a little bit more about acupuncture, some more of the specifics of treatments here. So when we evaluate the patient, again, it's a holistic evaluation. So the history includes everything in this pie chart here. So we're looking at nutrition, spirituality, stressors, relationships, exercise and fitness, emotions, life purpose and service. We also look at exercise, sleep behaviors, and different activities in your life. And then when we look at the physical exam, it's not just like we're looking at your knee or we're just looking at your shoulder. We're also looking at how your body language is, your face, your tongue, your pulse, sound of the voice, smell, sensitivity to touch. So we're kind of looking at the person as a whole, how you look like coming into the office. And going into the types of treatments. So again, we stimulate qi with acupuncture, but there's other ways to stimulate qi that's similar to acupuncture. So acupuncture here is on the left. This patient here has shoulder pain. And so he's got different needles and different acupoints that are the most common for shoulder pain. And you use needles to insert into the body. And sometimes you can add electricity to that. That's a stronger stimulation. You can move the needle. That's also a stronger stimulation. You can twist the needle. You can bring the needle up and down. You can also add heat to that, and that can increase the stimulation. Heat in a different way with herbals is moxibustion. And so this is a box, and in this box is a stick that has dried herbs in it. And in addition to the heat that goes on to the acupoint, it also has kind of a smell. But the herbal, in addition with the heat, can also stimulate qi. And that's kind of not as strong of a stimulation as acupuncture with needles, because with needles, it's a little bit more invasive and you get into the acupoint more deeply. So with cupping, again, that's not as strong of a stimulation. It's more of a pressure or acupressure. And what happens is you have these cups and you use a vacuum to take out all the oxygen from the cup, and then you put it onto the different acupoints or on different parts of the body. When you do that, you can see that the skin kind of puffs up in here and it's kind of pulling the skin there. That also helps to stimulate qi. Again, because it's kind of outside the body, it's not as strong of a stimulation with needles, but there's also different reasons why you'd use cupping versus why you would use needles. Treatment duration is about 30 minutes for treatment, and usually you do 1 to 3 times per week for treatments for 1 to 2 months. I did my training in China, and they did it like 3 times a week for 3 months. In the Western world, we just started getting it covered by insurance. Most insurance are covering it for like 10 to 14 times per year. So a lot of times we can stretch that out and make it effective. Even though, you know, probably more acupuncture treatments are more helpful. Why 30 minutes in terms of treatment duration? I think that it's a good question. There was a study that looked at it and showed that at 10 minutes was when the endorphin production started, and at 20 minutes, there's a maximum release of endorphins. So basically, the Western world is basically trying to prove what we've known for 4,000 years with traditional Chinese medicine and acupuncture. So I think that's a really nice correlation. Yeah, okay. The 30 minutes allows that full cycle of qi to circulate in the body. So those kind of worlds are kind of coming together. So auricular acupuncture, you might have heard of this too. There's a different map for the ear, and this is the musculoskeletal system, and you can use needles in the ear as well. It's a little bit different because you can keep the needles in the ear a little bit longer, but there's another way to stimulate qi and for acupuncture treatment. So indications for acupuncture, you know, there in the WHO in 2003 came up with 40 indications for acupuncture. It's treats different parts of the body, including the respiratory tract, GI, neurological conditions, musculoskeletal conditions. In 1997, the NIH consensus panel only showed evidence for dental pain and nausea. But really, acupuncture can be treated for a whole lot of different things. In Asia, they use it for basically everything. And there's two schools of thought, basically Western and Eastern kinds of medicine. Even things that we would treat with surgery, they would treat with acupuncture to start sometimes as well. And so there's studies going on that will hopefully increase this list. The NIH has a whole section dedicated to this called the National Center for Complementary and Integrative Health. And so I think that there's a lot of reasons that acupuncture can be helpful. I think there's a lot of things that it can be helpful for, and a lot of times it can be helpful to add on to treatments of Western medicine. And so that's why I kind of wanted to go into integrative health, integrative medicine a little bit. Because I think that, you know, I am a Western doctor. I went to medical school here in the States, and I think that there's advantages to both the traditional medicines in all these different countries and the modern Western conventional medicine that I learned. Traditional medicines have been proven effective for the last 3,000 to 4,000 years. They've shown to be safe with decreased side effects, and it's shown to be cost effective as well. And I think on the path to wellness, it's really important to get the best of both worlds, because I think that there are places where Western medicine might be better. There are places where Eastern and other medicines can be helpful, and to kind of use the best tools we have to get everyone feeling better. Okay, these are my references. And just some of my questions. I didn't put my email address on, but I can answer any questions over email as well. Just let me know. I can send you guys my email address.
All right. Thank you, Anna. We are flying through this morning. All righty. Next up, Sarah Height is going to talk about some scoliosis.
All right. Hi, everybody. Hope you're doing okay. Having a good morning. Let's get this going. Here we go. All right. So my name's Sarah Height. I'm a physical therapist at Emory. I specialize in scoliosis. I work at 59 Executive Park. And then soon we're going to be integrating back in at the new Musculoskeletal Institute. And so all I see essentially are patients with scoliosis. I'm trained in the Schroth method for scoliosis, which is just a treatment methodology that's based on the asymmetry that develops from scoliosis, and working to help improve posture. With adolescents, it's a little bit different, but that's actually what we're going to go through today. The basis, because the Schroth method is so specialized, I'm just going to kind of brush on it. Today, I want to talk more about what can be done in traditional exercise to help keep people with scoliosis fit throughout their life. And so the objectives, we're going to define scoliosis and kind of provide a brief background about the different types of scoliosis, what causes scoliosis, and then we'll talk about why exercise is so very important for people with scoliosis. And like I said, just briefly touch on what the Schroth method is, and then looking at a couple different kinds of exercise that are very common for people to do throughout their life, including Pilates, yoga, and then just basic core stabilization, what we can do to help modify that so that they're safe for people with scoliosis. So what is scoliosis? It's an abnormal lateral curve of the spine, and it has to be greater than 10 degrees. And so if you look at this x-ray right here, you see how it kind of curves like that. That's that lateral curve, and that's actually measured by something called the Cobb angle. You also have to have rotation. And so sometimes you can have this little side shifting, but no rotation. Usually they're very small curves, sometimes not even at that 10-degree level. And that's something where we have to look at leg length or muscle tightness, something like that, maybe contributing to it. So the rotational component, that's what we see right here. So that's when they're doing, this is called what's the Adams forward bending test. And so we're just looking to see, because as the vertebrae rotate, then the ribs have to rotate, and you develop this, what's called a rib hump. And so for all you ATCs out there, or coaches, or just parents who are concerned about their kids, it might be a good idea to every once in a while have your kids bend over and just see if they're starting to develop any kind of asymmetry, especially if For girls, they're anywhere from the age of 10 to, we'll say 14, 15, or for boys, anywhere from the age of, 13 or so up to 16, 17. Because it's one of those things where if we catch it early enough, you can talk to your pediatrician about it and see if it warrants a referral up to a spinal surgeon. So there's many different types of scoliosis: congenital, traumatic from a fracture, idiopathic. Those are the ones that we're really going to focus on today. You have neuro, whether it's from CP or polio. I definitely have seen patients, older patients in the past who have had polio, and that made them develop some asymmetry and a scoliosis. Or connective tissue disorders. That's actually something that there is a little overlap between the idiopathic. So if you have hypermobility disorder or Ehlers-Danlos, I see a lot of that correlating with the development of adolescent scoliosis or the progression of adult scoliosis. So prevalence of scoliosis this is looking at the specific age group. So in adolescents, that's about 2 to 3% of adolescents will develop scoliosis. And then unfortunately that increases as we get older. So once you hit about 25, about 6% of the population has scoliosis. And then as you get over the age of 60, there's some studies that say it can be upwards of 68%. And that's that degenerative component. Usually they're smaller curves, but it's still some kind of curving that occurs in the spine. And so in terms of prevalence from female to male, it's definitely more prevalent in females. And smaller curves, that's when you see it's only about 2 to 1. So boys tend to have smaller curves. But when you get up into those larger curve angles, that's when it's much more commonly female, about 7 to 1. So what causes the development and progression of scoliosis in adolescents? So you have some kind of triggering event, and that can be genetics, it can be nutritional, it can be dietary. There's a whole slew of different things that can play a role. But then what happens is it causes the vertebra to wedge. And then as a result of the wedging, you develop a curve. And then because you get a curve, then you get asymmetric loading, where there's more loading on the inside than the outside of the curve. And then unfortunately, that makes it so that the growth plates out here on the outside have more of a chance to grow than the ones on the inside. And so then that feeds into more wedging, and you can kind of get the cycle. And this is the theory that we base bracing and the Schroth method on for adolescents, that if we can take the loading off of this side of the spine, then maybe we can give these growth plates a chance to grow a little more symmetrically. In adults, it's a different story. So when adults develop scoliosis, there can be an underlying scoliosis from adolescence, and then they just start to develop normal age-related degenerative changes, or you can actually develop it separately in adulthood. So you get maybe a pretty large disc herniation, which then wedges the disc, and then it starts off this cycle of having the asymmetric loading. And then you can also develop osteoporosis. And so if you get a wedging because of maybe a slight compression fracture or something like that, then that again sets off the same cycle. And then at that point, it's a similar kind of asymmetric loading cycle. Then we also have to think about the force of gravity. And so you have the force of gravity pushing down on you for 70 years in this kind of curve. Over time, your muscles are going to fail, the support structure is going to fail, and you're going to fall further into the curve. So different curve types. There are 4 major curve types. The thoracic in adolescence is the most common. That's when you have that curve up there with the apex at around T8, T9. The next is the thoracolumbar, and that's when the apex moves down here to right at that thoracolumbar junction. And then lumbar is when the apex is down here in the lumbar spine. And then you can also have a curve where you have both. You have an apex in your thoracic spine and an apex in your lumbar spine. Like I said, in adolescents, this is the most common, but in adults, it's actually more common to have that progression and development of scoliosis in the lumbar spine, again, just because you're more common to have degenerative changes in your lumbar spine. Oops, here we go. So exercise capacity is reduced across the board in patients with scoliosis. It's just to what severity. And so they've done studies looking at patients even with mild curves, looking at their cardiorespiratory fitness, so through a 6-minute walk test or an incremental shuttle walk test, and showed that them compared to patients with straight spines, the patients with straight spines did a whole lot better. And so there is some kind of reduction. They're not 100% sure because in mild curves, it's not necessarily a structural problem with the lungs, because the ventilatory capacity is the same for straight spines and in scoliotic spines if the curve is very mild. But they think it has to do through decondition or something like that. And there's also a decrease in VO2 max. But unfortunately, as the curve gets bigger, that's when you start getting those actual changes in the pulmonary function tests. So decreased total lung capacity, decreased forced vital capacity, and then they actually have an increased respiratory rate at rest. So if we go over here and look at this chart, it kind of breaks it down a little bit better. So if you have a small curve, not really much change, but as they get bigger, that's when you really get those changes in terms of respiratory function. And so when it comes to adolescence, that's why we essentially want to stop it right here. We don't want it to get above that 40 degrees because we don't want them to develop these kind of problems. And so essentially that's where they pull the trigger, 40 to 45 degrees, depending on how much growth they have left. That's when they'll have to have surgery. Adults, and especially because the kind of surgery we do now is very different than what we did 10 years ago, is very different than what we did 20 years ago. There's still lots of patients that are in adulthood that didn't have the surgical option. And so I do occasionally see patients with 100-degree curves that are coming in on oxygen and having a lot of respiratory issues. And so we just have to modify their routine for that. So now we're going to look at the actual musculoskeletal mechanics of breathing in a patient with scoliosis. And so you can see a straight spine versus one that has scoliosis. And so there's definitely changes in terms of the intercostal muscles. There's changes in terms of positioning of the rib cage. On the convex side, the muscles are more stretched out. And then the muscles on the concave side are much more approximated, so they're tighter. And so what happens as you breathe in is that you don't get a lot of expansion here, you get a lot here. And then as you breathe out, you don't get a lot of compression here or depression of the ribs. And oh, I don't know what just happened. Sorry about that. What just happened? I clicked on something and it made me go, there we go. Sorry about that. So anyway, back to the rib mechanics. And so what happens is you actually develop this asymmetry in the ribs. And so this is looking at a right thoracic scoliosis. So on the right side, the rib hump sticks out, and on the left side, the rib hump posteriorly, and the rib hump goes more anteriorly versus this beautifully straight spine. You see how it's nice oval. And so what happens is they actually breathe more posteriorly to the right and more anteriorly to the left. And then again, as the curve gets worse, then you actually have to start relying on some of the accessory respiratory muscles. And then you have to think about the diaphragm also changes because there's a change in how the ribs are positioned. So switching gears a little bit, let's talk about treatment options. So the adolescents, like I said, it all depends on how much growth they have left, how big their curve is, and I mean, so usually their bone age and their actual age kind of correlate in terms of what they can do. So if they have a really large curve and they're very skeletally immature, then we're a lot more aggressive with their treatment because we don't want them to get to that 40 to 45 degree and need to have surgery. And so that's when coming to see me for Schroth and bracing, so full-time bracing or nighttime bracing, depending, is very important. Versus adults, it's really more based on pain. I mean, we can also look at it based on how big their curve is and how well they're able to function with their ADLs. And but it gets a lot more complicated because these surgeries are very, very big, very invasive. I mean, it's a long recovery period. And so it's one of those things where patients have to really be ready for it and ready for the recovery after the surgery. And so trying some kind of Schroth-based therapy is always good, even to help maybe get them a little bit stronger, a little bit taller, maybe improve their exercise capacity so that their recovery is a little bit easier. Versus if they have no pain, at that point, let's just work on keeping them fit, keeping them active, talking about modifications that can be made to their exercise routine. Like I said, neutral spine stabilization exercises, yoga, or Pilates without putting any asymmetric loading on the spine. So what are physical therapy scoliosis specific exercises? There are actually like 8 different ones, I think, in the world. The Schroth method is just one of the 8, and it's the one that's most highly researched and the one that is kind of the most common in the US right now. They're all curve pattern specific. So like I said, you can have a thoracolumbar, just thoracic, or, you know, what they call double major curve. And so we have to do our exercises based on that. And so the Schroth method, we use a lot of funky materials. So we have poles, belting. So she's actually connected into here to stimulate this principle of auto elongation. They're little wedges that we put under the back depending on where the curves are. And those are what kind of cue for that 3D spinal correction to derotate, like what we talked about, where you have that prominence. And then rotational angular breathing, that's just looking at helping to counteract that asymmetry that occurs in the rib cage. And then just learning how to stabilize the spine, because absolutely the core becomes dysfunctional in someone with scoliosis because everything is so rotated and twisted. This is just another graphic looking at that rotational angular breathing. So this is how a normal or scoliosis tends to breathe. And so we just want to breathe opposite that to help, again, create more expansion into those concavities and get a little bit more normal respiration. So the overall goals, especially in adults, is more looking at posture correction, getting them back to life, improving ADLs, stopping the curve from getting worse, and then reducing pain. And so these are just some good pictures of different postural correction exercises that we can do to go from being fallen into your curve and just kind of slumping to sitting more neutrally throughout the day so that you're not putting that asymmetric load on the spine. So what can you do? Again, the Schroff method is very specific, requires a lot of additional equipment, and so, but we can still do things to help patients with scoliosis be fit and active throughout their life. And so teaching diaphragmatic breathing and then teaching how to activate the transverse abdominis while diaphragmatic breathing, just getting a little bit of motion in the trunk musculature and the diaphragm working properly, using less of the accessory respiratory muscles. Then teaching neutral spine stabilization exercises. So avoiding sit-ups, avoiding Russian twists, anything like that that puts a lot of asymmetric load on the spine. We want to stay away from that. Posture education, just teaching them to sit upright. That can make a huge difference. And then body mechanics retraining. So looking at the hip hinge. So a lot of times patients with scoliosis, they really use their curve to their advantage. And when they bend over, that's where they don't keep their spine straight and use their hips. They just hinge right through their spine. And so teaching them how to avoid doing that. So this is just a good graphic showing these are the things that you want to avoid when you have scoliosis. Because like I said, any kind of flexion, side bending, or rotation really just puts asymmetric loading on the spine. The spine is not perfectly straight where the vertebrae are just wedging anteriorly, posteriorly. They're actually rotated. And so it's putting a lot of torsional stress on the spine as you go through those motions. Just some quick pictures of some core stabilization modification exercises that you can do. So planks all day. Bird dog, you can walk out on the wall, you can do anything laying on your back that you want, just anything that keeps the spine in neutral. And then if we go even further and look at some Pilates modifications, so using the reformer is great, using a Pilates chair is great, using a trapeze is great, just again avoiding, because with Pilates there's a lot of principles of kind of flexing in through the spine and getting that segmental mobility. Unfortunately, someone with scoliosis, it's not going to work. We can't, I mean, there is no way to get segmental mobility. They have flexion rotation going on in their spine, and so it's just going to kind of pivot. So we need to teach them to keep their spine straight and stabilize in that position and then breathe. Lots of cueing for the breathe. Just getting a little bit of expansion in their ribs can go a long way. And then yoga, same thing. So most yoga poses start in a neutral spine and then cue you for that end range rotation and spinal mobility. And so if you just get the patient to do the position and then hold it there and work on their breathing, the diaphragmatic breathing, that'll do a whole lot for them. Keeping flexibility in the hips, flexibility in the arms is very important for scoliosis because again, they like all their mobility to come from their spine. And so we need to teach them that their spine stays still and their shoulders and hips are the ones that are supposed to be doing the work. And so in summary, exercise is very important for people with scoliosis because they do have that decreased cardiorespiratory fitness and it can decrease over time as if their curve continues to progress. And so if we can do anything to keep them strong, keep them fit, it'll help to prevent that curve from progressing. We just have to make sure that whatever exercises they're doing are good for them and not necessarily hurting or potentially putting more asymmetric loading into the spine. So that's where we want to stay away from end range spinal rotation, side bending, or flexion. Of course, you can do stuff within normal mobility of life, but we're talking about repetitive end range. And so really just focusing on neutral spine and then spinal elongation. So a lot of thinking of that string on the top of your head, thinking about being tall, thinking about posture correction can go a long way for these patients. All right, all done. Thank you so much.
All right, thank you, Sarah. If anyone in the audience has any questions, if you would put them in the Q&A at the bottom of your screen. We're going to do a panel discussion. here. We don't have any questions at the moment, so if any panelists have any questions for each other. I know we're a bit ahead of schedule, so there's a talk going on in room 2, the benefits of weight training. If any of the audience members want to jump over into that chat during that talk, you guys are welcome to do that. We'll put some questions in the Q&A for us and we will get those answered for you. Silence on a Saturday.
Everybody must be ready for lunch.
Oh, hang on, we got a red thing. All right, with Pilates, this person says she uses pillows under the deviated side to feel curves. Is that yes or no for scoliosis?
So there is a lot of information out there online about how all you have to do is find your curve and put like a pillow or a wedge or a foam roll under your side and just lean to it. Unfortunately, what happens is it becomes a lot more complicated than that. If you have a single, like say you have a 14-year-old who has just a single thoracic curve and they have no other degenerative changes, no other risks for listheses or things like that, then, you know, that might be okay. But what happens is a lot of times with adults, they have some kind of secondary curve that has developed in their lumbar spine. And so if you're just side bending in your upper curve, what's happening is you're pivoting and overloading that lower curve, especially if it's what we call a fractional curve. And so that right there, it's kind of like a pivot point. And so they're really at risk for developing listheses, so the actual slipping of the vertebra, or, you know, it's just, there's a lot of mobility going on there. And so I would be careful with that. I wish that there was an easier way to answer it. It might be better just to know if it's an adult, just do nothing under them. Because like I said, the padding is a little bit more specific. You have to have an x-ray, you have to know exactly what's going on with the spine. And you just have them lay there and think about elongating and breathing. That can be a whole lot more beneficial than trying to pad or put something under them. I hope that helps.
Thank you. All right, we have a question about the ACL prevention program.
Okay.
She says, have you seen any other ACL prevention programs outside of FIFA 11 Plus that are being used in other sports with success?
So there's research on a few, but the most studied and the most proven one to be effective is the FIFA 11 Plus. And that's, you know, pulling exercises from it to adapt it to your other sports. You know, I worked with cheerleading when I was doing athletic training at Georgia, and we didn't use the FIFA 11 Plus, but they did a lot of other cheerleading exercises that helped out with their stability and tumbling and things like that, and landing, especially when they were throwing each other up in the air. So really just taking aside maybe 10 to 15 minutes twice a week in practice to work on balance and work on strengthening of those lower extremity muscles, rather than just practicing drills with sports, taking time to really focus on that prevention and small little meticulous things can help.
All right, thank you. All right, we got another question happening here. Acupuncture versus dry needling. Are there benefits for each?
Yeah, so dry needling is mostly the treatment we do for trigger points. And so that's why I kind of wanted to I touched on it on my lecture a little bit. That's a little bit different. When you're doing dry needling, and it depends on who's doing it for you. I do it in the office in physical therapy. Someone who is licensed, who has the training for it, can do it as well. With dry needling, you basically are looking for the spot that hurts the most, and you're looking for a muscular trigger point. And usually it's pretty tight in there, it's pretty painful. And dry needling is putting the needle in there and keeping it in there for a while. When I do dry needling, I also go in and out with the needle a few times to kind of break up that muscle bundle in there. Acupuncture is a little bit similar because you use a needle to put, you can use a pain point or an ashi point where you kind of feel where the pain is. And you can do similar things. You can use the needle to go up and down and to kind of move it around. So it's a little bit different of needle technique. And then you leave it for 30 minutes. And for trigger points and dry needling, I don't typically leave the needle in. I basically move the needle in and out, kind of break it up. Sometimes I put some medicine in there like lidocaine to kind of help with that. When you get dry needling in physical therapy, what's nice is that you can get multiple treatments, and oftentimes you get multiple treatments, say, once a week or something like that. So I think that they are similar, and they have similar kind of treatment aspects to it. I think they're both helpful in different ways, probably because trigger point and dry needling is more of a mechanical stimulation of an area, versus acupuncture can work in an area far away from where the problem is. So they're similar, but they're different. I think they're both can be helpful. Depends what you have.
Thank you. All right, we have one more ACL question here. Looks like, are there return to sport testing measures done in the clinic for patients after an ACL reconstruction?
Yes, so we do a ton of return to sport testing. ACL rehabilitation can take, up to a year. So when we're sending athletes back on the field, we do a lot of hop testing. So this is all about single leg stability, because that's that situation that you're going to have that injury, either non-contact or contact. Usually it's in a single leg position. So we make sure that the athlete has a stable hop on the single leg. We do a lot of agility drills and things like that to make sure that they are confident going out on the field, to make sure that they have good control of their lower extremity. So I know we have a whole battery of tests that we use, and there are a ton of specific ones, like the single leg hop, the time hop for distance, the crossover hop test. We look at tuck jump, things like that, to make sure their landing mechanics, the drop jump test. So there's a lot of stuff we use when we're sending athletes back onto the field.
Great. Thank you. We got one more question here on the scoliosis. Are there common athletic injuries that occur due to or secondary to the scoliosis?
Yes, for sure. It's really common to get shoulder injuries, especially if you have a thoracic scoliosis, because think about what happens to the rib cage. It rotates, and so you develop that sort of impingement position just naturally. And so that's where using the Schroth method or using some kind of elongation to help stabilize or open up the rib cage a little bit, improve their posture, that helps to get their shoulder kind of back where it's supposed to be. Hip injuries are very common, especially depending on which side they have a lumbar curve, because what happens is it actually creates a functional leg length discrepancy. It's not true, because if you can help to open up their curve a little bit, their pelvis becomes more neutral, but you can see a lot of glute med tendinopathy, things like that, a lot of hip bursitis. And really what we have to work on, because you can work on the hip all day, but it doesn't matter, they're still going to be standing slump like that. So working on helping to get them up tall into that more neutral posture. Of course, back injuries, because I mean, that's where the scoliosis is. And interestingly enough, one of the most common complaints for scoliosis is neck pain. And so neck pain is very, very common in patients with scoliosis, just because of maybe the additional thoracolumbar or thoracic kyphosis that occurs. And so again, that's where that postural component comes in and is very beneficial.
Thank you. Anybody else have any questions for our panelists, or panelists have questions for each other? Now we will wrap things up here. All right, I got nothing else popping up in the Q&A down here. Thank you, ladies, for taking your Saturday morning to be with us this morning. There will be a presentation in room 1 right before the lunch break. It's labeled Nutrition in the Female Athlete, Fueling to Promote Health and Prevent Injury. That will be in room 1, so if you log out of here and jump into room 1, if you want to listen to that. Otherwise, this room will restart after lunch at 1:30 with Across the Spectrum of Sport. Everybody have a nice lunch break.
Bye, thank you.
You're welcome.
All right, Jennifer, do I just need to keep this room open?
Yeah, do you want me to leave it until after lunch, or do you want me to go ahead and make you the host?
It does not matter to me. I'm just gonna leave it up and mute myself and turn off the video and go have some lunch.
Okay. I'm just clearing out some of these Q&As so they're not there for the next one. Okay, all right, then let's try it. I will leave. If something happens, just send me a text and I will rejoin.
All right, great. Thanks, Jennifer.
Good. Meeting, that makes you the host.
You're still recording. Do you want to?
Oh, I forgot.